Hello, welcome to Lecture 5 in the Practice of Cardiac Sonography 1 unit. The title of this lecture is An Introduction to Image Interpretation. The contents of this lecture are 1. Two-dimensional image measurements. 2. M-mode image measurements. 3. Hemodynamic measurements. And 4. Doppler measurements. There are 4 lecture learning outcomes. That is, following this lecture, you will 1. Define specific normal 2D and M-mode cardiac chamber measurements. 2. Define certain normal cardiac chamber pressures. 3. Define specific normal Doppler measurements. And 4. Identify certain abnormal 2D and M-mode measurement values. The textbook, once more, is Essential Echocardiography, in particular chapters 4, 5, 6 and Appendix 1 are most relevant. Other sources, as per the most recent Practice of Cardiac Sonography lecture, that is lecture 4, this lecture I also recommend that you make reference of and read through the recommendations for cardiac chamber quantification by echocardiography in adults, which is a document available via Views, and also see the Western Sydney University Echocardiographic Reference Values document. Echocardiography is the most commonly used non-invasive cardiac imaging modality because of its unique ability to provide real-time images of the beating heart, combined with availability and portability. The recommendations document I just mentioned in the previous slide states that the quantification, that is, the measurement of cardiac chamber size and function, is the cornerstone of cardiac imaging. Normal values from the recommendations document have been incorporated into the Western Sydney University Reference Values document, and I will refer to this particular reference values document often throughout this lecture. Introduction. Like all other organs, the size of the heart varies. Variations are due to differences in body size, gender, age, and health. It's important to account for these variations by indexing according to body size, that is, according to the patient's height and weight. Body surface area is calculated by the equation on the bottom of this slide, which you do need to be mindful of, but do not need to memorize. Two-dimensional measurements. 2D echocardiography is the basis of morphologic and functional assessments of the heart. 2D images provide high-resolution images of cardiac structure and their motion, and enable the measurement of cardiac anatomy and function. The foundational aspects of developing strong skills in 2D imaging, which are an essential part of this unit, were introduced in preceding lectures and will be extended in this lecture. 2D left ventricular linear dimensions. When measuring linear LV dimensions, parasternal long axis images are used. Parasternal long axis images are used because they enable perpendicular alignment with the long axis of the left ventricle to be consistently achieved. Certain linear measurements are used more often than others. The 5 measurements marked with a star on this image and their normal ranges for men and women are measurement ranges that you as cardiac sonographers will need to be very familiar with. In particular, you will need to commit to memory the left ventricular end diastolic diameter and the bottom 2 measurements, the septal and posterior wall thickness and the septal and posterior wall thicknesses that allow for the calculation of LV mass. So to begin with, may I encourage you to memorize the uppermost normal values, that is, values for the left ventricular end diastolic diameter for men and women. (2D) left ventricular outflow tract dimensions. Linear measurements of the LVOT are required from the parasternal long axis view. The plane is often slightly different from that used to make linear measurements of the LV, as the reference for the LVOT measurements is the long axis of the ascending aorta. A proximal LVOT diameter is measured in mid-systole, 5 to 10 millimeters inferior to the aortic valve hinge point. Measurements should be made observing an inner edge to inner edge technique. 2D aortic dimensions. Like measurements of the LVOT, linear measurements of the ascending aorta are made from the parasternal long axis view, and the plane will be the same as for the LVOT measurements. That is, you need to observe the long axis of the ascending aorta. Unlike LVOT measurements, which require an inner edge to inner edge technique, linear measurements of the aortic root, sinotubular junction, and ascending aorta require a leading edge to leading edge technique. Normal values, absolute and indexed, of the aortic root, sinotubular junction, and ascending aorta differ slightly between women and men, where values for men are slightly greater than the values for women. (2D) RV dimensions. As mentioned in the last practice of cardiac sonography lecture, RV dimensions are best measured from the RV-focused apical 4-chamber view. Remember, to optimize the RV in this view, lateral movement of the transducer is most often required. Care should be taken to obtain an image with the LV apex at the center of the sector without opening the LVOT, and by having an image that displays the largest basal RV diameter. Two RV dimension measurements you will need to be very familiar with are the basal and the mid RV dimensions. Normal ranges are indicated on this slide, and measurements shown in the image at the bottom. RA area. As the right atrium is not easily visible in two orthogonal views, an RA area is most often used to quantify the RA. RA area is best measured from an RV-focused apical 4-chamber view by zooming further to show the RA Its area is then calculated by tracing the tissue-to-blood interface in the 4-chamber view. A normal RA area is less than 18 centimeters squared. The images at the bottom of the screen show 2 RA area measurements. The image on the left of the screen shows a normal RA area. The image on the right, a clearly abnormal RA area measurement. 2D left atrial volume measurements. As indicated in the last lecture, left atrial volume is now the standard way of measuring left atrial size. Left atrial volume is the standard measurement because of its ease and advantages over linear measurements. Left atrial volume is measured by tracing the tissue-to-blood interface of the left atrium in zoomed apical 4-chamber and zoomed apical 2-chamber views to achieve a biplane measurement. The normal reference values for an indexed left atrial volume is the same for men and for women. The normal range being 16 to 34 millimeters per meter squared. Mild, moderate and severely dilated values are also shown on this slide. M-mode image measurements. M-mode measurements are made by identifying the interface between structures. And diastole measurements are made by identifying the LV when it's its largest. Secondarily, reference to the QRS complex on the ECG can be made. And systole measurements are made when the LV is smallest. And again, reference to the T wave on the ECG can be made to ensure timing. Normal M-mode values of the left ventricle are detailed on this slide. Like 2D measurements of the LV, the most frequently measured dimensions are the LV chamber in diastole and systole, and the septal and posterior wall thicknesses, most often measured in diastole. M-mode measurements, which have slightly different reference values, should be made to complement, not replace, 2D measurements. M-mode measurements of the aortic root and of the left atrium can also be measured. Again, these measurements should be made to complement, not replace, 2D measurements. Normal values for these measurements are also indicated on this slide. Hemodynamic measurements. Blood flows continuously through the blood vessels of the cardiovascular system to support life. As you will remember from the Principles of Cardiac Sonography lectures, when the pressure P at the inlet of a blood vessel, PI, is different to the outlet pressure, PO, blood flows from inlet to outlet. However, blood flow is limited by resistance, that is, from the friction between blood and the blood vessel walls. Blood flow, Q, is therefore related to pressure and resistance. Flow, Q, equals the pressure difference divided by resistance. The cardiovascular system is comprised of blood vessels with different anatomical features, which help to support their hemodynamic function. That is, arteries normally have thick muscular walls because they must support the blood travelling within them, which is under high pressure. Normally, arterial blood pressure exceeds venous blood pressure. For example, The systolic pressure in the aorta is normally around 120 millimeters of mercury, whereas pressure in the vena cava is almost zero. Arterial pressure fluctuates between systole and diastole. This is due to the pulsatile action the heart uses to eject blood. In contrast, venous pressure fluctuates very little between systole and diastole, because the pulse pressure diminishes as blood travels through the cardiovascular system. The heart is the driving force of the circulation. Like the blood vessels into which the heart ejects blood, the chambers of the heart have different anatomical features which help to support their function. The atria, which serve largely as conduits, are thin-walled. In contrast, the ventricles, which force blood out of the heart, are very muscular. Forward blood flow in the heart is facilitated by the synchronous contraction and relaxation of chambers which generate and maintain pressure gradients, and is also aided by functional valve motion. Pressures within the chambers of the heart and great vessels is not the same. The unequal pressures ensure the forward movement of blood. The table on this slide provides important normal adult intracardiac pressure values. Notice that normally the pressure in the atria are least. The pressures on the left side exceed the pressures on the right side. And the pressures vary according to the phase of the cardiac cycle in which they are measured, where end systolic and end diastolic pressure in the left ventricle is the most variable. Low end diastolic pressure in the ventricles is necessary to ensure normal ventricular filling from the atria. The types of hemodynamic measurements that cardiac sonographers make include the measurement of blood flow, that is, the measurement of the direction and velocity of flow, and the measurement of intracardiac chamber pressures. Doppler imaging in its different forms enables the measurement of blood flow and intracardiac pressures. The different Doppler forms that enable this are pulse wave Doppler, continuous wave Doppler, and color Doppler. Doppler measurements. Doppler echocardiography measures blood flow and tissue movement in the heart and great vessels. Doppler has replaced many invasive cardiac procedures for measuring hemodynamics because, if done well, Doppler measurements can be very accurate. As mentioned in the previous lecture, Doppler imaging has strengths and weaknesses, which a sonographer must be aware of in order to optimize the strengths and minimize the weaknesses. To ensure accurate Doppler measurements, first and most importantly, the ultrasound beam should be aligned as near as possible to parallel to blood flow, or to the plane of the moving tissue. Adjustments should also be made to gain settings to ensure an optimal display without excessive noise, scale settings like baseline and sweep speed to help identify the maximum velocity, and the sample volume for pulse wave Doppler, and the color box size for color Doppler. Pulsed wave Doppler measurements. Pulse wave Doppler is used to measure left ventricular inflow. Peak E and A wave velocities, as well as the E wave deceleration time, are measured. measurements of left ventricular inflow should be made from the apical four-chamber view. When measuring left ventricular inflow with pulse wave Doppler, color Doppler should be used to guide the placement of the sample volume. This is to ensure that 1. The pulse wave sample volume is placed at the level of the mitral valve leaflet tips, and 2. That the alignment of the Doppler beam is as near as parallel to possible, that is, as near as possible to parallel to LV inflow. It's important to realize that LV inflow occurs at about 20 degrees lateral to the LV apex, and that this angle increases with increasing LV size. Therefore, alignment of the beam with LV inflow will require particular attention in patients with dilated hearts. This slide gives normal E and A wave velocities, normal E over A ratio, and deceleration time values. Normal values will be covered at greater length in semester 2 when diastolic function assessment is covered. For now, the most important points to remember are covered on the 2 preceding slides. That is, that LV inflow is measured from the apical four-chamber view, that the ultrasound beam should be aligned and sample volume should be positioned at the LV mitral leaflet tips, and the alignment and positioning should be guided by color Doppler. Pulse wave is also used to measure left ventricular outflow. Measuring flow in the left ventricular outflow tract is best made from the apical 5-chamber view. Color Doppler should be used to help align the ultrasound beam. The pulse wave sample volume should be positioned approximately 0.5 to 1 centimeter inferior to the aortic valve hinge point. The peak velocity should be identified and a trace around the outer edge of the entire waveform made to enable the calculation of the velocity time integral. A normal pulsed wave Doppler waveform of the LVOT flow is V-shaped, and the acceleration slope should be greater than the deceleration slope. A normal maximum velocity range is from 0.7 to 1.1 meters per second in the LVOT. Continuous wave Doppler measurements. Continuous wave Doppler is used to measure blood flow at multiple sites. The measurement of blood flow across the aortic valve is one of the most common. Measuring flow across the aortic valve is frequently made from the apical 5-chamber view, although, as we will see later on, there are other views from which it can be measured. Like pulsed wave Doppler, color Doppler should be used to align the ultrasound beam to ensure the beam is parallel to the direction of blood flow. The peak velocity should be identified and a trace around the outer edge of the entire waveform made, again to enable the calculation of the VTI, the velocity time integral. A normal velocity across the aortic valve, normal peak velocity, is 1 to 1.7 meters per second, and a normal aortic valve area, calculations for which we will cover in semester 2, is greater than 2 centimeters per meter squared. Continuous wave Doppler also allows the measurement of pressure gradients, that is, the difference in pressure between two chambers. By measuring the peak continuous wave Doppler velocity and by applying the Bernoulli equation, that is, the equation on the screen, velocities can be converted into gradients. You'll learn more about the Bernoulli equation in Principles of Cardiac Sonography 1 Physics lectures, and of its application in Semester 2. For now, it is important to understand that continuous wave Doppler allows intracardiac pressure gradients to be measured. The pressure most commonly estimated with continuous wave Doppler is pulmonary artery systolic pressure. To do so, from an apical four-chamber view, the right ventricular systolic pressure is measured by using a continuous wave Doppler beam to sample the peak tricuspid regurgitant signal. The tricuspid regurgitant maximum velocity is an estimate of right ventricular systolic pressure. Right ventricular systolic pressure plus right atrial pressure equals pulmonary artery systolic pressure. A normal value for pulmonary artery systolic pressure is less than 38 millimeters of mercury. Other pressure estimates and alterations. Continuous wave Doppler can also be used to measure pulmonary artery end diastolic pressure by measuring end diastolic pulmonary regurgitant velocities, left atrial pressure by subtracting the peak mitral regurgitant velocity from the systolic blood pressure, and left ventricular end diastolic pressure by subtracting the end diastolic aortic regurgitant velocity from the systolic blood pressure. Pulse wave Doppler and tissue Doppler imaging can be used to estimate left ventricular end diastolic pressure. Again, these will be covered in greater detail later in the course. What's important to remember is that Doppler enables these pressure gradients to be estimated. Intracardiac pressures can be briefly changed by a forceful expiration against a closed nose or mouth. This kind of forceful expiration is called a Valsalva maneuver, which can be used by sonographers to help in the estimation of pressure gradients when normal measurements are ambiguous. The Valsalva will be discussed further in Semester 2 when LV diastolic function assessment is considered and assessment of flow dynamics in such conditions as hypertrophic cardiomyopathy. Color Doppler. To recap, color Doppler uses pulse wave Doppler principles. Multiple sample sites along multiple beams are used to measure the Doppler shift at each site. The mean Doppler shift is displayed in color. Red color indicates blood flow towards the probe. Blue color indicates blood flow away from the probe. The useful acronym being BART, which helps you to remember that blue is away, red towards. So, looking at the image on the slide, remember that the apex of the sector is the point from which the beam is transmitted. On this image, red color indicates flow towards the probe from the bottom of the image towards the top, that is, from the left atrium to the left ventricle, and blue indicates flow away from the probe from the top towards the right of the display, that is, from the left ventricle to the aorta. As color Doppler uses pulse wave Doppler principles, it is subject to velocity limitations, that is, to aliasing. It's important to observe and adjust the scale so that unwanted aliasing does not occur. At other times, aliasing can be utilized to identify turbulent flow or to measure regurgitant lesions. Tissue Doppler imaging measurements. Tissue Doppler imaging displays the velocity of moving targets in the myocardium. The most common target for tissue Doppler is the septal mitral annulus, although the lateral mitral annulus is also a common target. The left ventricular S' measurements 1 and 2 on the image on this slide reflects left ventricular systolic function. Left ventricular E' measurements 3 and 4 on the image reflect left ventricular diastolic function. As indicated on the table, a normal septal S' velocity is approximately 8 centimeters per second, and a normal E' velocity is approximately 9 centimeters per second. It's important to appreciate that tissue Doppler does not analyze the spatial displacement of the myocardium, but the direction and speed. Therefore, the units for tissue Doppler are centimeters per second. Tissue Doppler is also used to measure RV systolic function by measuring the tricuspid annulus movement. As indicated on the table here, a normal RV S' value is greater than 10 centimeters per second. So, in conclusion, due to variations related to body mass, it is important to index measurements according to the patient's weight and height. 2D linear measurements of the left ventricle, the left ventricular outflow tract, the ascending aorta, and RV are standard echocardiographic measurements. 2D left atrial volume is a simple and valuable measurement. The Western Sydney University Echocardiographic Measurements Reference Values document provides normal and abnormal reference values, which you should be familiar with. To ensure accurate Doppler measurements, attention must be given to alignment, gain, scale, and sample volume placement. Doppler, that is pulse wave, continuous wave, color, and tissue Doppler, allow the measurements of things such as left ventricular inflow, left ventricular outflow, peak velocities and pressure gradients, as well as left and right ventricular function. This lecture has included a lot of information related to the acquisition of echocardiogram images and how to interpret measurements made on those images. Acquiring images, making measurements, identifying the appropriate reference value, and deciding on whether or not image measurements are normal are skills that take time to develop. So I would encourage you to try and apply what you've learnt in this lecture into your imaging practice as soon as you can, and encourage you to remain patient and ask those who are there to help you to do so as you try to further develop your imaging skills.